Hi, this is Elliot Fishman, and I'm back for part 2 of CT protocol design and optimization, how we do it. In part 1, we went through a lot of the details in optimizing protocols, thinking about oral contrast and IV contrast, design of protocols, a lot of the basics that relate to contrast material. In this second part, we're going to look more at some of the other parts of protocols, looking at some of the design and optimization of the specific protocols. Now, as I mentioned, 64-slice CT is really the standard these days, and with 64-slice CT, there's always 3 big factors to me: spatial resolution, temporal resolution, and isotropic datasets. Typically, spatial resolution is under 0.4 millimeters. With dual source scanners, you're talking about under 0.3 millimeters. Temporal resolution is typically in the 160 to 180 millisecond range. A dual source under 75 milliseconds. And you have isotropic datasets, which means that you can scan in a single plane and reconstruct in any plane with the same quality. Now, when you think about CT and its developments, there was one application that has a small part of CT but has driven, and that's been cardiac CT. And the reason is everyone's competing who can do the best cardiac CT at the lowest dose with the best resolution. Well, the good news is everything that was developed for cardiac CT works for everything else we do. Cardiac CT is the biggest challenge. You have a moving structure and you're trying to look at a vessel that's a few millimeters in size and detect the presence of a stenosis of 50% or greater. So when you look at the left coronary artery in this case, you can very nicely see the vessel and its extent, the minimal non-calcified plaque. But you can really look at a single vessel that small and track it out. That's really where CT is these days. Well, I will tell you that it's the same with everything else. You may look at this liver mass and say there's a large mass in the right lobe of the liver, and this is not a very subtle case in a cirrhotic liver. But if you look at this mass with MIP, you now see the neovascularity. You're looking at those very tiny small vessels that feed the lesion, and there's so much interest now in neovascularity because of many of the new drugs, including tyrosine kinase inhibitors, but the fact that you can look at the neovascularity and determine the aggressiveness of the tumor, what the ideal drug might be, what the response might be. You have maps, so if you want to resect the tumor, embolize the tumor, whatever you want to do, we're able to use the original CT scan for that information. We could look at tumors like this where you see some vascularity in a multifocal hepatoma, but again, look at that neovascularity. It's very, very hard to get that same information by just looking at the axial CT. I'll go back the slide. It's somewhat vascular, but it's not that impressive. It surely isn't as impressive as this image. So what we're looking at in CT is, as far as I'm concerned, almost every study we do is a CT angiogram, because every study has IV contrast, or almost every study, and we inject quickly, we have thin sections, we can create beautiful maps. So we look at things and the importance of the maps. We spoke, or we speak about things like liver masses. I showed you hepatoma. This is FNH. One could just say, oh, it's a big liver mass. But what is the mass? Well, you look at the mass, there's a central scar. The mass is enhancing, not as bright as the aorta, but only as bright as the IVC. If you do a 3D map, you see a large feeding vessel to the central portion of the tumor. That's a classic visualization for focal nodular hyperplasia. Or another example, same disease, FNH. It's a benign lesion, but look at that central scar. You see the feeding vessel going to the scar? I'll accentuate it. There's the feeding vessel. Here I go to a little bit more MIP. There's the vessel right to the center. There's no neovascularity. It's a smooth vessel, goes right to the central scar, classic for focal nodular hyperplasia. As we do multiple phases, the lesion becomes less dense. You vaguely see it here. You see the scar. You see the vessels being stretched. And when you look at things in sequence from arterial to venous to delayed, you see how lesions behave. So much what we do in CT in designing our protocols is making sure that we have the information that allows us to get the diagnosis. We don't want to say a mass is a mass is a mass. We want to be specific. You can't always be specific, But when you design the protocol correctly, like multi-phase for looking at liver masses, you're able to look at key points. We look at enhancement levels. We're looking at the vessels. We're looking at the central scar. We're looking at behavior. And you would not confuse that lesion with this lesion. Here's an enhancing lesion. This is not a hemangioma. Hemangiomas have peripheral puddling, but here the lesion is entirely enhancing around its edge, and there's a halo around the lesion. And that halo is indeed very important because that halo means there's microvascular invasion around the lesion, and you could do the MIP imaging and you see the neovascularity. The only question to me here is what's the primary? I guess theoretically it could be hepatoma. This was metastatic neuroendocrine tumor to the liver. Could be renal cell potentially, but the point is the appearance of the lesion tells you everything. Now, I mentioned isotropic data sets, and with 64 slice or better, we always have isotropic data sets. It's very important to recognize, and we've spoken about this, that you need to routinely create multiplanar images in all cases. You could do it on a workstation. The easiest thing to do with newer scanners is have the technologist do it at the scanner. You can build it into the scan protocol. The computer does it automatically and ship it to the radiologist. It's been my experience when the images are already created, radiologists will more commonly look at them. If they have to do it themselves, they're not going to look at it. We also like 3D imaging. Some people like 3D generated by the technologist or by a 3D lab. I like to do it personally. But however you do it, it's very important to recognize that that provides critical information in many cases that the surgeon, oncologist will need to manage the patient. It's important to remember that information available from a CT is far more than what's on axial slicing. We're acquiring information in a volume with isotropic data. You need to look at it in a volume. There have been many articles, and this is not related to radiology, in other fields that make the same point, that when you explore large data sets, in order to understand, you need to visualize structure. Visualization is the process of transforming information into a visual form, enabling users to observe the information. The resulting visual display enables a scientist, engineer, or radiologist to perceive visually features which are hidden in the data but nevertheless are needed for data exploration and analysis. That is indeed very important. If I show you these axial images and I put an arrow right there and I ask you what that dot is, you don't know what that dot is. It could be a tiny vessel, it could be a small node, it could be whatever. But if I take that and reconstruct it, now you see that's the patient's left adrenal vein, which is a critical structure. It's only a couple millimeters in size, but it's a critical landmark when you're doing a laparoscopic nephrectomy. And you see that vessel 100% of the time. If you look at the axials, you see it 0% of the time. You don't recognize it, but in 3D, it's so obvious, it's so easy to see, and that indeed becomes very important. The amount of information I get from a study. Now remember, I've already scanned this patient with Crohn's disease, and I'm asking you to tell me about this patient. The radiation dose has been used already, and you could say to me, well, the axial images show thickening of the ileum, Crohn's disease. There's a little bit of inflammation in the mesentery. Okay, that's correct, but is that all the information? If I go to coronals, what I then add is I get a better feel of the length of disease. I can see the entire bowel loop involved. I see the length of involvement. I see the relationship to the vessels. That works very nicely. But now if I take that same data set and I do MIP imaging, now look how well I see the vasa recta and the very prominent vessels. Prominent vasa recta in a patient with Crohn's means it's active disease, which means the patient needs aggressive treatment. Now with MIP imaging, I don't appreciate the bowel wall well, but I appreciate the bowel wall vessel interface and the vessels. But if I go one step further, and now I look at the volume rendering, now I see the vasa recta, I see the bowel, I see areas of stricture, abnormal enhancement. And think about it, this image is a composite of over 1,000 slices. What would you rather look at? What would the surgeon rather look at? 1,000 slices or this image? By looking at this image, there's so much more information than scrolling. Or in this case, patient with chest pain, you look, there's blood inside the pericardium. You look at the ascending aorta and you really notice this outpouching. This patient has a pseudoaneurysm. But describing it, look how much easier it is to describe the pseudoaneurysm. You can see its relationship to the prior surgery. You can see its relationship to the patient's right coronary artery, to the ascending aorta dissection. Easy to see because in the volume, things are easy to see. There have been a number of articles. This was a couple years ago from Pam Johnson. By supplementing traditional axial interpretation with 3D rendering of the CT volume, the greatest amount of information available is extracted. Post-processing is thus no longer an option, but a true requirement in this era of 64-row multi-detector CT and beyond. And that indeed has been our experience, and that is what we consider. If you look at our experience at Hopkins, it's been many years looking at 3D imaging. We started on the Siemens system. These PDP-11s can make some bizarre images. In the mid-'80s, we worked with Pixar and then Next and Sun and SGI, developing workstations that initially cost $300,000 or $400,000 to the point now that we can use the iPad with NVIDIA boards for a few $100s and create real-time 3D rendering. So lots has changed. Image quality, this is on the Siemens way back when, 1982. If you're really good, you know that's the hips. Or you look at this film from Lucasfilms and you say, oh my God, what is that? Well, that's the first image. It was 84 images rotating that shows you the ability to show bone, muscle, and fat. This was the so-called fat lady. And we wrote articles about this. Volume rendering differs from surface rendering, and that all the information is preserved, not just surface boundaries. Within a few years, we're able to get images with this quality. And remember, this was CT pre-spiral, 4 millimeter thick sections every 3 millimeters. We even scanned the entire body. Only took about 7 hours in 2 X-ray tubes, and it was a cadaver. And then it took about 7 Pixar machines, about 4 days, a number of millions of dollars worth of computers, but you could do it. We can do the same thing today, scan that patient in under 20 seconds, and on my iPad, I can reconstruct it in real time. So things have definitely changed. When you look at the reconstructions, and here's just an example, this is reconstructions off an iPad, okay? So you're using a $600 device for doing and displaying reconstructions, which means that 3D is no longer just in the lab, but it's anywhere we are, whether it's on an iPhone, whether it's on an iPad, and perhaps soon on your iWatch, though I think the iWatch may not be the place you're going to see this information. When you look at post-processing tools, there's so many different tools now. In the old days, we had one tool and we used it for everything. Now we have bone editing tools, vascular segmentation tools, coronary has packages, stent placement has packages, colon has packages. There are so many different packages available. It's important to have the right package at your institution and the ones you need for the work you need to do. It makes things more efficient. The ability to remove bone often was a challenge, but with new techniques, watershed transform, we wrote about a number of years ago, the ability in this case of cirrhosis, and you're looking at the liver, spleen, and the ribs, and here would be a 3D, and the bone would be somewhat annoying to be in the way. Well, the computer automatically can remove the bone. And there you are, just looking at the liver, spleen, and the vessels in this patient with portal hypertension. Nowadays, we can even do it in some ways easier. We can do dual energy CT, and dual energy can subtract bone automatically. And it does better than many of the bone algorithms. And so look how nicely and quickly you can show volume rendering or MIP imagings. Dual energy is on the high-end scanners. It's soon to be on the lower-end scanners. It's important to recognize that we deal with the K edges, which vary for each element, and the increase as atomic number increases. And you can see why iodine, which has a K edge of 33, versus calcium with a K edge of 4, and that's why we're able to segment the two things out. With dual energy, you can run it the typical Siemens way, which has 2 X-ray tubes running at different KVPs, typically 80 and 140. Or GE with a single source with very rapid KVP switching. Both work well. The GE uses on their gemstone detector, and that works very nicely. Again, the certain advantage, of course, is that you can scan the entire volume, and it works very nicely. And the Siemens with 2 X-ray tubes, again, allows you a little bit more limited field of view, but it works very nicely because both data sets are required exactly the same time, so there's precision in terms of those data sets. And there's lots of interest in dual energy as sort of a second contrast material. It's dose neutral. Again, the good news is we're able to do the dual energy without increasing dose to the patient, and in many ways we can decrease dose because we can use less IV contrast, we can create virtual non-contrast CTs, for example. So indeed it becomes very important. And you can see with dual energy, very nice bone removal, very nice vascular mapping in a matter of seconds. Several articles, article by Postman, bone removal in dual energy allowed easier and faster acquisition and post-processing. Removal of bone at the skull base was of concern, but with dual energy it's much better. I think with classic bone removal, skull bases were impossible. With dual energy, it indeed works very nicely, routinely, all the time. There still is some errors. Very dense contrast can cause artifact. Look at the patient's right subclavian coming in, and you see the artifact, which creates what looks like an occlusion of the vessel. It looks like occlusion of the left carotid proximally. You can see the left carotid obviously is patent, so you need to be very careful. Sometimes very dense contrast can be problematic. There's ways of getting around this. Use less dense contrast or decrease the injection volume, or scan just a touch later. But again, with every technique, you need to understand the potential pitfalls and work around that. I'll just mention a couple other things about dual energy. One of the things that's touted for dual energy is looking at gout, the ability to detect the presence of uric acid deposits. Again, it does work well. It's not perfect. And again, how often do you need CT to look at gout? But it is an example of the ability to look at different structures, different energy levels, different materials. And so perhaps it's a good way for us to think about, perhaps we can use dual energy, and Satomi Kawamoto at Hopkins is looking at this, looking at pancreatic tumors, for example, to determine the aggressiveness of tumors, to determine how tumors respond to therapy. Can you predict whether response is working? But dual energy has a lot of potential features. This is a patient with gout, the green being the increased uric acid deposits. And another example here, you can see the bony changes involved, and here's the dual energy. People have used this as a way of quantifying the degree of gout, the degree of uric acid deposits, and then look at therapy. So there are many possibilities, but it is a good marker and a good way of thinking about where dual energy can potentially go. As dual energy becomes more available, I think we're going to see a lot more interest. To date, it's always been the high-end machines, and there has not been a lot of literature. So it's still something that in many ways is a work in progress, but I think it has a lot of great interest. Now, one of the things also we recognize is that there are many things that are being developed that require new software and potentially hardware that have a cost to them but can help us with work. So for example, there are new programs that calculate the volume of nodules. This will become very important with lung nodule cancer screening because we want to see if there's growth in nodules, if there's any change at all. In oncology patients, instead of doing a single line measurement, RECIST measurements, perhaps we should look at volumes. Volumes are more accurate in looking at response. So there are programs now which calculate the response, calculate the volumes, calculate change. We talk about virtual colonoscopy. Virtual colonoscopy works very well. Its accuracy is the same as classic colonoscopy, but it's not been as widely accepted. That's because the people who refer to colonoscopy are the ones who perform the colonoscopy. So it's really not been used all that much. We use it at Hopkins occasionally with failed classic colonoscopy or patients who are not very cooperative. But you can see very nicely, we're able to look inside the colon. The prep is the same as colonoscopy. People are working on virtual preps, and if you can do a virtual prep, I promise you, our volumes will increase. One issue, of course, is it's very cost effective. This article in the New York Times talks about the fact that colonoscopy is very expensive because often it has an anesthesia charge. Patients who underwent sigmoidoscopy had lower rates of colon cancer and lower cancer deaths, but you really need to look at the entire colon. So again, CT is ideal, and in this article of recommendations, the New York Times doesn't even mention virtual colonoscopy. They rather have a patient undergo sigmoidoscopy than a virtual colonoscopy, and that's just plain crazy. But again, it's something that's been a battle for a number of years, reimbursement and acceptance. And I think time maybe will help us out, but I'm not that positive. Cardiac CT was an issue in terms of a lot of conflict between radiology and cardiology. Once cardiology saw the reimbursements were so terrible, they became a little bit less aggressive, and it varies from site to site. We do somewhere between 20 and 40 cardiac CTs a week, many after hours. The results of cardiac CT have been very good. There are many different articles that show the high accuracy for looking at stenosis. The most important thing in the ER setting is a 99% negative predictive value. If the coronaries are normal or there's no critical stenosis, patients can't be discharged. It used to be said that 2/3 of patients who went for cath had a normal cardiac cath. One of the things we do is by being a gatekeeper, we decrease the number of unnecessary catheterizations, which also decreases the number of unnecessary stents. 99% negative predictive value. Cardiac CT is hard to do. You need to train your technologists. The newer scanners make it easier, but remember, you're looking at a small vessel, you want to minimize the dose, and you want to be able to detect the presence of stenosis. So the quality of the study is everything. When I have a good quality study, it's very easy for me in this example to say that the right coronary artery is normal. Or in this case, that the patient has mixed plaque and there's approximately a 50% stenosis when I look at the full range of images. But if there was motion present, I wouldn't be that successful. Another big area that's become accepted as part of routine cardiac care is calcium scoring. It's now recommended by many societies. It's also now being paid by many insurance companies to get a calcium score. Now, a calcium score you have to think about as one more lab test. It's kind of like getting cholesterol. You have a normal cholesterol, it tells part of the story, but not the whole story. Calcium scoring, we look for the presence of calcium, the Agassiz scoring system. The ideal is to have a score of 0. But one thing we've learned with CT angiography is that a score of 0 does not necessarily mean you don't have plaque. And that's an issue. This patient has a score of 0, but look at the patient's right coronary artery. It essentially is occluded. There it is right there with a score of 0. So indeed, calcium scoring works very well, but it's only one more value. It does not tell you what the coronary arteries look like. That's where coronary CTA really comes in. Some people have suggested over age 50 or 55, with doses dropping, perhaps a coronary CTA should be done. A lot of decisions will go into that if that's going to become a reality. I don't see that happening anytime soon, but it's something indeed perhaps would be valuable. With the role of measuring this degree of stenosis, new software has come along. The software is not perfect, but it's getting better, both for quantifying the amount of plaque, both calcified plaque and now non-calcified plaque, as well as able to quantify the degree of stenosis. There are all sorts of measurements we can do, from volumes to cardiac output. So there are many things we can do, and the area of coronary CT and cardiac CT continues to grow. And again, it's very technology dependent. New scanners like the Force, for example, will make coronary artery imaging much easier because the scanner is so quick. It's really like a froze motion. People talk about the 320 from Toshiba as a way also of doing cardiac CT. The GE systems, of course, work very nicely as well, but again, it's a matter of how well you use the system. One thing we could think about is that 64-slice CT and beyond is what Andy Grove, one of the founders of Intel, would call disruptive technology. It changed everything. But in order for us to move forward, really it's this integration between data acquisition and visualization techniques that become important. As we've spoken, just simply looking at axial images is not going to be enough. We need to look at the volumes, and we need to use the specialized software. An important part of what we do in terms of radiology also is our relationship with our referring physician and with our patients. One of the challenges radiology has, this article by a good friend, Gary Glazer, who passed away a couple of years ago, makes the point that people don't know who radiologists are, and the danger of us becoming a commodity, that although teleradiology is good for getting consultation and for after hours, but perhaps it simply makes us one big commodity, that it's an individual or invisible radiologist isolated from patients, that if you do a study in Baltimore, you can read it as fast in California or India or China or anywhere else as you can in Baltimore. And it's really a problem for radiology because we don't want to be a commodity. It's important that radiology has direct communication, and only by direct communication can we really change this idea of what we are. Now, a great part of that is personalized radiology as a way of personalized medicine. Now, it's not always possible for us to speak to every patient. Let's be realistic about that. If you're in angiography, okay. If you're doing mammography, okay. When you're reading CTs and the patients are coming off the scanner 5 times an hour, it's great to try to say hello to some patients, but you're not going to spend time talking with every patient. What is important, however, is to work with your technologists. They're your outreach. Make certain the technologists are speaking to the patients. Make certain the patient has an excellent experience. Make certain the patient knows you're there and that you're available if they need to speak with you. Also, it's important for us to be part of the process, work closely with referring docs. We need to be the ones who know what the right test is. We need to perform the test correctly, interpret it correctly, and provide the information for patient management and be involved in management. Things that are critical are multidisciplinary conferences. In the old days, clinicians would walk around and visit you because you had the film. Now everybody has the film, right? It's all electronic. It's very easy to be separated from our referring docs. Well, in radiology at Hopkins, we're part of 25 or more multidisciplinary conferences. I'm at every pancreatic conference, whether it's the pancreatic cancer or pancreatic cysts or adrenal. It's important that you go to those conferences. You look at this article talking about cysts and how we have this multidisciplinary conference. Look at the article. The first authors were from GI and from surgery. Then there's the pathology. Then there's radiology. Then there's surgery and GI and oncology. So you really see it's truly multidisciplinary, and when you do that, you understand the flow of how we manage patients. You understand the role and challenges of radiology. It allows us to really understand what we need to do. It allows us to help answer the correct questions. A multidisciplinary input is helpful in the management of patients with pancreatic cysts. Up to 30% of cases found the same thing with prostate, found the same thing with pancreatic cancer. We see the same thing with adrenal. This article looking at the cancer center, okay, provided this change in management at 1/4 of patients. You had everybody in the same room: medical oncology, surgical oncology, radiation therapy, radiology, pathology, nursing, pain management, and the like. It's really the way things need to be done. It's critical for radiology. You can see from this study how important we were. The majority of changes in management were the fact that we did dual phase 3D mapping. It's very, very important. Other articles from Hopkins. Here's an article by Wolfgang. It is clear that multidisciplinary care that provides comprehensive and coordinated evaluation and treatment is the most effective way to manage patients with pancreatic cancer. You can drop the last 2 words and put anything in there. We need to be part of the process, and I think radiology, when you're getting reimbursed for RVU, there's a great problem. You want to read as many cases as possible. When I go to conference, it takes me an hour and a half in conference. I'm reading no films, but I'm providing incredible value. I know that some groups, when they figure out work, they give people credit for those conferences with a certain amount of RVUs. Maybe that's the way you need to do it in your practice. It seems a little bit much to me, but whatever works. But I think you need to be there. You need to be there at the table. And the other thing is, personally, I'll tell you, I learned so much. You need to know what the surgeon wants to know, what the oncologist want to know. It makes you a better radiologist because your reports make much more sense. Now, in radiology, I think things that are going on around us are going to change what we do. The area of 3D printing is something that becomes of great interest. You see it in the paper all the time. It's even in Wikipedia. In March 2014, surgeons in Swansea used the 3D printed parts to rebuild the face of a motorcyclist who'd been severely injured in an accident. 3D printing is an emerging technology. Now it's kind of cool. You see things in the newspaper or on TV, but I think it may be the way things are going. It's proven valuable in other industries, but it's the same thing. It's happening. When you do a search, you see here it's true in ophthalmology. Here it's true potentially for organs and for creating organs. Here we're talking about neurosurgical models. Here we're talking about dynamic chest CT models. you can see the quality. We've been looking at that, and I'll show you something we did. Here was we scanned a lot of animals from the aquarium. This was a shingleback skink, or skink, probably more correctly said. And you can see how nice the animal looks. And here was a requisition. This was from Kate Hatfield, who's one of the key people at the aquarium, one of the veterinary people. And of course, you realize that you get much better history from the aquarium than you do from many of your referring physicians, and you could see what her main concerns were. And of course, at times, I try to be really prompt, but at times I'm not. And here was a letter just to show you sometimes I'm just a little bit late getting the report back. But when we scan the animal, that's the slices, that's the lung, that's the outer part, that's the shell, the scales. And you can see CT does a very nice job of looking at that. And the detail, very impressive. Okay, and look at the face. So really good detail. We then took this to MakerBot and created the model. It's impressive how good that 3D model looks. Imagine surgical rehearsal on these models. Imagine the learning we can do. Here's the CT scan above, and that's the model below. That indeed is very, very impressive. So I think you're going to see 3D printing in radiology, custom stents perhaps, preoperative planning for complex surgeries, perhaps in radiation therapy, and also perhaps, if it gets cheaper and quicker, as a patient communication tool. Now, another thing, when you think about CT, you think about, we look at the images and we say, I see the image and I'm looking for pathology. But you know, remember, the images were really 0 and 1s. In the old days, it was computer printouts. Well, can we extract more information from our CT scans, either for lesion detection or for analysis? And the answer, I think, is yes. There's been a lot of work being done on texture analysis. And what we did in this study was looking at patients with various liver tumors, try to determine, simply by drawing a circle around the tumor, what precisely the tumor was. And you could do a lot of thematical formulas, and I won't read this for you, but a random forest technique was used to analyze the data. It creates many different parameters to try to define what you're seeing within the data set, and it creates all of these charts by using very, very fancy mathematics. But when all is said and done, what happens is that you're able to classify tumors, what they are specifically, based on their mathematical formulas. Look at the accuracy. Adenomas, 91% of cases, FNH, 94%, hepatoma, 98%, error rate of 4.2%. High specificity, high sensitivity. And when you compare that to the readers, we had our best readers, they were 72% at best accurate. Okay? So texture analysis did this much better than our readers. Texture analysis provides quantitative measures of heterogeneity from the distribution of pixel intensities at different spatial frequency within a region of interest. While this technique has previously been used to predict outcome of tumors, now we're able to perhaps use it for lesion discrimination and characterization. And we did this with liver, we've done this with kidney now, we're doing it with lung. There's many articles published looking at lung cancer, renal cancer, and many of the articles basically make the point that you're able to predict how people will respond to certain therapies, certain tyrosine kinase therapies in renal tumors. So I think what we need to be thinking about is, when we look at the CT, that's almost a view from 50,000 feet. We need to put a microscope to the CT. That's what texture analysis is doing, so I think that may be very exciting. And you can see that's how it separates the individual tumors. And you can see how much better it did than the radiologist. That's the radiologist, and that's the computer. The same thing is true of renal masses, from oncocytoma to clear cell to papillary to simple cyst. The same software was used, and this article is now recently published, but this random forest technique was able to create a predictive model to classify lesions. So again, very good results. So very, very important. This is going to be one of the areas, I think, where CT really plays a major role. So it's not going to be just reading the CT, it's going to be data analysis after that takes place. A good quote by Albert Einstein, amongst his many good quotes: not everything that can be counted counts, and not everything that counts can be counted. There's no doubt things are changing for all of us. We talk about devices, how we look at things. I mentioned our initial 3D workstations were $400,000, but things change. The iPad came along, and you say, well, so what? How will that help us in medicine? Well, the iPad and the iPhone, particularly the larger iPhone, which to me is the 6 Plus is a mini iPad, allows us to be able to look at images anywhere and everywhere. A number of articles in the RSNA News speak about this. It now is getting FDA approval. There are many different companies making this software. We use the one from Siemens at Hopkins, the web viewer, which we helped develop. The point is that you're able to look anywhere and everywhere. I could be traveling and I can consult. I can look at images, give second opinions. You can read the images the same quality. We've looked at this with PEs. We've looked at that with coronary CTAs. It's the exact same quality. And everything is changing. The server-side rendering and processing allows you to have the information, but it's not on your device, so it's HIPAA compliant. There's no issues. The images are available everywhere. The image currently being viewed on the device is the only one that is stored at that point in time. So if someone steals your device, they have nothing. And the quality, the iPad, Apple does a good job. Steve left behind some really talented people. I mean, look at the quality. You can do multiplanar. You can look at things with any perspective. You can do 3D. You do interactive rendering, and it's only going to get better. When you look at the results that have been published, here was some of their results. Emergency CT brain imaging, same quality as a classic workstation. The tablet displays potentially a device which will make remote interpretation more feasible. Another article looking at the brain. Tablet technology will assume a major role in provision of expert radiologic opinion to remote sites in the acute setting. It's everywhere, anywhere. Here's an article from Hopkins talking about looking at PEs, that when you look at PEs, whether on a workstation or you look on a mobile device like the iPad, the accuracy is the same. So now you have the information everywhere, and it's not just for the radiologists, it's for the referring docs. They can see their information wherever they are, in their office, in their car. They can, hopefully not while they're driving, of course, they can look at the information with the patient at the bedside. It becomes a very strong patient education tool. Now you can ask, will the iPad replace traditional workstations? Will the iPad provide all of the applications of a standard workstation? Can it do cardiac? Can it do PET? The answer is it can do almost anything you want it to do, as long as you write the software correctly. Will it replace workstations? I don't think so, because workstations give you a lot more flexibility, including capturing images, and everything's in one place. But on a case-by-case basis, it really is a small workstation. And these things are only going to change. You've seen these articles about Apple meeting with FDA. You know about the Apple Watch, all of the things that are being developed, the iPad, the iPhone, the watch, and devices from Samsung, devices from Google. Other companies are coming along as well. Everything in healthcare is changing because of this mobility. So it indeed becomes very, very important. Now, another thing to really look at is just how we think about things. So a very important part, and I mentioned this before in terms of protocols, is really not only designing the protocols correctly as step one, but then thinking about what needs to be done. How do we interpret information? You have to answer questions. With pancreas, we talk about presence of a mass, enhancement, duct dilatation, adjacent organs. We talk about looking at things. We talk about reporting. And I mentioned this before. What about using templates? The question, should we use templates, is indeed a very good question. I mentioned before, if perhaps referring physicians will like templates. There's been several articles that suggest they do. So it will be something that perhaps will be one of the changes. So not only will we be looking at images differently, but how we report them will be different. So in many ways, one of the things that we like to look at in this series of talks is that radiology is not yesterday's radiology. Radiology is changing every day, and I think it's very important for all of us to really be on top of that change. We need to be leading the change, whether it's in how we look at the images or how we report the images or what we participate in. indeed becomes very critical. At Hopkins, one of the things we did last year, trying to figure out a way of thinking differently, was we had 7 visitors come to speak with us. We had a range of incredible speakers, from Ed Catmull, who's the president of Disney and Pixar, who at that time just released his book on creativity. We had Horst Schultes, who ran the Ritz-Carlton and now runs the Capella Group, talking about excellence in quality, how we deal with customers. Whitney Fishman spoke about the importance of the web, the importance of social media in dealing with patients. Eric Becker, who's a big venture capitalist, spoke about how you need to deal with patients just like their family. Cindy Wolf, who's a world-famous James Beard chef, spoke about the importance of experience, the importance of the patient being the single most important thing to us. Paul Greenberg spoke about how we run, how we manage things, how we need to manage our enterprise, from the physicians to the technologists to nursing to escorts, how we need to have a very structured system, hire only the best, and challenge people to perform at their maximum. We had Bill Phillips, who's the editor of Men's Health, speak about how younger people expect things differently, how hospitals fail because hospitals treat when you have disease. We need to be more aggressive on the preventive side of things. We learned many things from these people that have challenged all of us. We did it again this year. We had a number of other speakers from Freeman Rabowski, who has been excellent on developing new talent, who's the president of UMBC in Baltimore. We had Marla Kaslowitz, who's the CEO of MEC Corp in New York, again talking about creating the right environment for doing things. Or Tina Wells speaking about how things are changing and how the new millennium generation that we work with as patients and employees really changes and their expectations change. We learn many things. Good enough isn't enough, and that's true with CT. You need to do things excellent. If you're doing it good enough, you're not doing it good enough. Good enough, Horst Schultes said, is just above bad. We looked at this quote. This is Eric Becker. What are you tolerating but shouldn't be? We need to make certain that what we do on a daily basis is the right thing. We need to restructure. Sometimes we say, well, it's too hard. It's always been done this way. Well, you need to really change. All of those lectures are articles that are coming out of the JACR, and you could read them. And I'll share you one of the first articles that came out. 3 of them have now come out. This was from Horst Schultes. Your department may be composed of some of the best physicians in the world, and you may know more about medicine than some of your competitors, but that doesn't matter. If you don't understand how to optimize service for your customers, all the medical knowledge in the world will not be sufficient for your business to succeed. How you create an environment in which customers are given timely, satisfactory, and courteous service. You have to hire the right people, give them a chance to work in an environment of belonging and purpose. Very, very important words. Horst Schultes, you can find some of his talks online. They are spectacular. Patients do not typically have a good sense whether or not you're providing care that is excellent or average. Their opinion of your business and the consequent financial success of your healthcare enterprise is much more contingent on their experience with you and your staff and the physical appearance of the healthcare environment. We need to let people know we're there. As radiologists, as radiology technologists, we are there and we care. We must be involved with the entire process. We need to speak to our patients. We need to introduce ourselves to our patients. We need to be there. After all, the quote goes on, as we wrote this article, although we like to think that medicine is somehow completely unique and different from other fields, we are fundamentally running a service industry that shares many features with other consumer-focused industries. Now, that may make medicine sound bad, but it's not. We're saying is we need to be excellent. We need to be excellent in all aspects of our job. We've become radiologists and radiology technologists. We know what we want to do. Steve Jobs mentioned and always was clear about focus. We need to focus in CT on doing things right, preparing the patients for the study, acquiring the studies correctly, interpreting the studies correctly, delivering the right information to the referring physician. We need to be 360 involved, doing things perfectly, successfully, all of the time. It's a challenge, it's hard, but it's something we should strive to do. And with that, I thank you for your attention.